Welcome everybody, and I would like to thank you that your early morning on our session. This is a joint session between European Association of Percutaneous Cardiac Interventions and Bulgarian Society of Interventional Cardiology. This is an initiative which we started with Professor EAPCI for 2 years ago, and this second joint meeting session during our National Congress. Our guests will be Dr. Ryan, Dr. De Rosa, Dr. Kina, and the topic of this session will be chronic coronary syndrome, just an actual topic in intervention, in cardiology in general, because I think that the last year guideline started to change step by step our practice, and Bulgarian cardiologists still need some training and education in this area, especially in functional coronary assessment. Moreover, that as you know, we have very good reimbursement about these procedures now, and there is no problem to do any functional tests for our patients. Unfortunately, Dr. Jan could not arrive, and she recorded her presentation. We'll see the record, and then she will be on Zoom, will join to us for a short discussion afterwards. So I would like to ask our technical team to start the presentation.
Good morning, everybody. My name is Nicola Ryan, and I'm an interventional cardiologist in Aberdeen Royal Infirmary, and it's my absolute pleasure and honour to be invited by the Bulgarian Society of Interventional Cardiology to this session in conjunction with the EAPCI. I've been given a very large topic to cover, and as always, when we're asked to consider the diagnosis of chronic coronary syndrome, we turn to the guidelines. The most recent 2024 guidelines for the diagnosis of chronic coronary syndrome ask us to carefully consider the patient's history, risk factors, and their baseline investigations, and with this, to determine the pretest probability of obstructive coronary artery disease. Based on the pretest probability, we're then guided to either initial assessment with CT coronary angiography, functional imaging, or invasive coronary angiography. And whilst both CT and functional imaging are very important, this is an interventional meeting, so I'm going to focus on the role of invasive investigations, both for the assessment of obstructive epicardial coronary artery disease, as well as patients with no obstructive coronary artery disease. This is a typical patient that we see in our cath labs every day. Classic exertional angina, risk factors, proceeded directly to coronary angiography. And we see here in the LAD, in the mid-segment, we have 3 intermediate stenoses in tandem. Now, this is not something that from angiography alone we can say is definitely obstructive or definitely functionally significant, and I think the majority of us would say this is something that requires further assessment. Depending on the techniques and technology we have available in our cath labs, we may choose to do a non-hyperemic indices, something like an IFR, and here we get a distal spot of 0.8, or we may choose to proceed to a hyperemic index, so an FFR. Again here, we get an FFR of 0.78 distally, and historically, this would have been our red light or our green light. We take our distal measurement. If we find that our FFR is greater than 0.8 or our non-hyperemic index is greater than 0.89, we stop, we don't put in a stent. If we find that our FFR is less than 0.8 or our non-hyperemic indices is less than 0.89, we have a green light, go ahead, put in a stent. And obviously there's a large amount of data to support this. A lot of us are aware of the FAME2 trial. That's a large trial published back in 2012, the 5-year follow-up, where we had 888 patients who were randomized to FFR-guided PCI, or optimal medical therapy. They all had stable angina, and the primary endpoint was death, MI, or urgent revascularization. And we can see here that the PCI group had a significantly lower primary endpoint than those who were treated with medical therapy. And again, looking at the breakdown, this was primarily driven by urgent revascularization, but there was a reduction in MI in the PCI group. And this has been supported by numerous other trials. For our IFR, we have Defined Flare, we have Sweetheart. If we look at FFR, we obviously have the original FAME trial, we have R3F, we have Ripcord, we have an abundance of data to support this. However, we now, in 2025, know that our distal measurement is only a minor part of a physiological assessment. And now, when we see an FFR of less than 0.8 or a non-hyperemic indices of less than 0.89, we don't see it as a green light to go ahead and stent. We're aware that we need some further assessment of the patterns of disease throughout the artery, and we attempt to carry out a longitudinal assessment of the vessel. And to do this, we carry out a pullback, so either an IFR pullback or an FFR pullback. And why is this important? So obviously, I'm showing you here two IFR measurements. They're both exactly the same, 0.87. And if we think back to our simple stop-go, well, we have a green light to put a stent in both of them. But if we take a more careful look at our pullback, if we look at our pullback here on the left, we can see we have a relatively steady state, followed by a sharp rise in our pressure, and again, a relatively steady state. If we look to our pressure pullback on the right, we have a gradual pressure rise throughout the vessel. And again, from this, we can understand that on the left, we have a focal stenosis, and on the right, we have diffuse disease. And this is not new information to us. We're well aware as interventional cardiologists that stents work very well for focal stenosis. We can relieve the obstruction in that area of the vessel. However, in diffuse disease, a stent is not necessarily the best option. Again, looking at this image here, I can predict that if I stent from here to here, I am most likely going to relieve this obstruction, and I'm most likely going to be able to transpose my pressure wire pullback gradient from here to here. However, if I put a stent here in the diffuse stenosis, I'm unlikely to make a significant change to my pressure wire pullback. And this is something we've known as far back as 2014, where Suk Niger and colleagues from Imperial College carried out virtual stenting based on an IFR pullback in 32 vessels in 29 patients. And based on this pullback and predicted PCI, they then went ahead and carried out the actual PCI, and they showed a very good agreement between the expected post-PCI IFR and the observed post-PCI IFR. And it's something that many of us have been incorporating into our clinical practice since then. However, we then had a larger investigation, so the PPG Global Study, or the Pullback Pressure Gradient Global Study, and this is carried out by Carlos Collette and colleagues in Aalst. It's a very similar concept, except on this occasion, it's an FFR, and it's an FFR pullback under hyperemia. And again, we can see here, they're showing a focal coronary artery disease with a step, or we can see a diffuse pullback gradient. And the software here calculates the pullback pressure gradient. So here, a high pullback pressure gradient, 0.81, suggests focal disease, while here, a lower pullback gradient is suggesting a more diffuse pattern of disease. And in their study, they had over 1,000 patients who had coronary artery disease and an intention to perform PCI based on a distal FFR spot. The operator then carried out a pullback gradient, and in almost a fifth of patients, the operator changed their strategy. So these were all patients who were planned to undergo PCI based on a positive distal FFR. However, 100 patients or 100 vessels, the operator changed their strategy from PCI to optimal medical therapy. And in 50 patients, 54 vessels, the operator changed their strategy to coronary artery bypass grafting. And that was due to the presence of a diffuse pullback gradient and the belief that a good result would not be achievable with PCI. And again, when we look at adverse cardiovascular events in this study, whilst it doesn't meet statistical significance, we do see that patients with diffuse coronary artery disease were more likely to have target vessel failure, and they were more commonly had myocardial infarctions, both spontaneous, post-procedural and peri-procedural MI. So this gives us some useful data to carefully evaluate our pullback gradients. Whilst we don't have long-term outcomes, and we do need more information about this, this is something that when we're evaluating our individual patients in the lab, we need to consider if we have a patient with a diffuse pullback gradient, are they somebody that we are going to serve best with PCI? Is it somebody we should consider optimizing their medical therapy? Or indeed, is it somebody that might be better served by our surgical colleagues with a coronary artery bypass grafting? Again, this is a slightly different example, a patient with a typical angina who has a mid-LAD lesion. They underwent a pressure wire pullback. Their distal IFR was positive. We see here they have a significant rise where their LAD lesion is. And interestingly, this is not something that's easily appreciated on the angiogram, but there was also a rise in the proximal LAD. However, of course, it is above 0.09, it's probably 0.91, 0.92 here. They went on to undergo PCI with a good angiographic result, and we then evaluated their post-PCI physiology. This is out with the topic here. However, we know that our post-PCI physiology gives us a guidance. We don't have hard data, but it gives us a guidance as to whether we need to consider further optimization of our stents. If we move on to the group of patients who have a very classical symptoms of angina, we're very convinced they have chronic coronary syndrome based on the history they're telling us, their risk factors. However, when we proceed to angiography, we see something like this. We either see completely normal coronary arteries or somebody who has some mild plaques within their coronary tree. And when we assess it with an IFR or an FFR, we're not seeing any significant obstructive coronary artery disease. This is very common, and we've known this for many, many years. And it is, of course, because our coronary angiogram only gives us information about our epicardial arteries, and that is all that our FFR or IFR evaluate. We also have the microcirculation, our small arteries, our arterioles, our capillaries. And we've known for many, many years from our PET studies that our coronary flow reserve and our microvascular resistance give us good information about the function of our microcirculation. And in the cath lab, we have a couple of ways to assess patients who have angina with no obstructive coronary artery disease. First of all, we need to consider, do we want to assess their endothelial independent function? So this is something that we assess with our adenosine, so our IMR or HMR if we're using a Doppler wire, and our coronary flow reserve, our classical microvascular angina or coronary microvascular dysfunction. Or do we want to assess for endothelial dependent microvascular function? So what we classically know as our pyramidal angina or vasospastic angina that we can assess with our acetylcholine. So I think more commonly we're becoming very familiar with the reduce of adenosine to assess our CFR and our IMR. Our CFR, our coronary flow reserve, is a ratio between the hyperemic flow and our resting flow. And now that we have our thermodilution and our pressure wire X in clinical practice, I think most of us are very happy to assess it. Our coronary flow reserve, again, we carry out a thermodilution, so we inject our saline through our guide catheter, and it travels to our distal thermistor on the wire, and we get our mean transit time, so our time for the saline to travel from our injection to the thermistor, and we carry that out at rest. We induce hyperemia with adenosine, and we repeat the measurements during hyperemia. Our coronary flow reserve is a nice simple ratio, so our mean transit time at rest, 0.43, divided by our mean transit time at hyperemia, 0.1. Simple maths gives us a CFR of 4.3, 4.2. The software calculates it for us automatically. Our IMR, or Index of Microcirculatory Resistance, again, this is an assessment at hyperemia of our distal pressure times our mean transit time. And again, we can get this from our pressure wire X. Our hyperemic mean transit time is here, and our PD during hyperemia is up here, 79. So 79 times 0.1, again, relatively simple maths, 7.9, or the system rounds it up to 8. So when we're looking at no obstructive coronary artery disease and we're looking to assess for coronary microvascular dysfunction, normally we would expect that a person has high vascular tone at rest. We induce hyperemia, and during stress, we get a low vascular tone, and therefore our CFR is high and our IMR is low. In patients who have coronary microvascular dysfunction, when we induce hyperemia, we can have two different endotypes or two types of coronary flow reserve. We can have our structural, so those who have a very high vascular tone at rest. We induce stress and they're unable to dilate further. So they have a high vascular tone during stress and they have a low CFR and a high IMR. Or we can have what we call our functional endotype, so patients who have exhausted their capacity to dilate, so their vascular tone at rest is low. When we stress them, they're unable to dilate any further. Their vascular tone remains low at stress and they have a low CFR and a low IMR. Again, looking at our cut points, they're helpful. A CFR of less than 2.5 is considered low or abnormal, and an IMR of greater than 25 is high and is abnormal. So in patients with coronary microvascular dysfunction, we expect to see a low CFR, with either a high or a normal IMR. We know we do have this slightly unusual group where we can find a normal CFR but a high IMR, and this group of patients are typically those with a high BMI. Again, when we're looking to the long-term outcomes of these patients with coronary microvascular dysfunction, we have a very nice meta-analysis published earlier this year. We know that in the patients that have a concordantly normal CFR and IMR, so low CFR, low IMR, they have low MACE, low death rates. In patients that have an abnormal CFR and an abnormal IMR, so a low CFR and a high IMR, they have high MACE rates, they have high death rates. These are typically our older patients or hypertensive patients, more typically male. If we look at the group that have an abnormal CFR and a normal IMR, so a low CFR and a low IMR, they are a group that have a medium and an intermediate risk of MACE and an intermediate risk of death, and they're typically our female patients. And again, the last group that I was just discussing, those who have a normal CFR with a high IMR, those are typically our patients with higher BMIs, and they've low MACE, low death rates. So if we move on, we can think about patients who have potentially vasospastic angina, and these are patients that we would like to assess with acetylcholine. So in the UK, we don't have access to acetylcholine except in eye drops. It's used off license, and every time I use it, I have to sign a form to assure everybody that I'm aware it's off license. We typically make this up in the cath lab, dilute it in the lab. And we start off, there's various protocols. This is the EAPCI recommended protocol. The protocol that I use in my lab is I give patients a test dose and infusion of 18 micrograms a minute over 2 minutes. I then give them an infusion of 36 micrograms over 2 minutes. And finally, I give them a 200 microgram bolus over 20 seconds. And after each infusion, I do a small test injection to see, am I inducing any spasm? Obviously, I have continuous 12-lead ECG monitoring, and the patients are assessed clinically. To have a diagnosis of spasm, we need greater than 90% reduction in the vessel caliber, ischemic ECG changes, and nitrate responsive chest pain. So again, this is a patient who had previous history of undergoing PCI to some very distal vessels under the care of one of my colleagues for a history of angina. However, he continued to have ongoing angina post-PCI, and we know this is very common. There's a significant proportion of patients who, despite successful PCI, have ongoing angina. So he returned to the lab, and from an coronary angiogram point of view, things look okay. So we proceeded to a microvascular CMD assessment, and we can see here he's a normal FFR, a normal CFR, and a normal IMR. So he doesn't have coronary microvascular dysfunction. So we proceeded to acetylcholine testing. And this case, actually, this was the 18 microgram test dose. He obviously has occlusive spasm with ECG changes and typical chest pain. And this resolved really nicely with intracoronary nitrates. So what do the guidelines tell us? The guidelines tell us that we should have the ability to carry out functional assessments to confirm or exclude our diagnosis of obstructive coronary artery disease and angina or ischemia with non-obstructive coronary disease in patients who have uncertain diagnosis on non-invasive testing. Why is it important? Well, obviously, once we have a diagnosis, we can risk stratify our patients, we can optimize their lifestyle, we can monitor their risk factors, and we can stratify their medications based on the underlying diagnosis. And obviously, it is important to get the diagnosis correct, and we're all very aware of the CORE-MICRA study, where patients underwent an invasive diagnostic procedure, so they had CMD testing and they had acetylcholine provocation. And in the group of patients who were treated based on the findings at their invasive diagnostic procedure, they had improved angina and they had improved quality of life that was ongoing. And importantly, particularly if you work in resource-limited settings, they had reduced healthcare usage over time. So my key messages are, for me, the history is key. It's like everything, back to our university days, speaking to our patients, understanding their story. If they present with a good history of angina, even if we do find that on a CT coronary angiogram they have normal coronary arteries and their symptoms persist, we should consider invasive testing. If we come across obstructive coronary artery disease on a spot physiology assessment, we need to understand that better. We need to perform a longitudinal assessment with physiology. Whilst we may not have the long-term data, I think we're still learning, we're still evolving, we're still understanding the benefits of focal versus diffuse disease and the treatment options for them. And finally, chronic coronary syndrome, our decision-making, it doesn't need to be time-pressured. We have time to allow our patients and their families to reflect on the treatment options and the risks and the benefits of both. Thank you very much for inviting me to this session, and I look forward to the discussion.
Имаме ли връзка с доктор Райан? Hello, Dr. Ryan.
Good morning. Apologies, I can't be with you.
Thank you. Thank you for participating in our Congress, and that was really great overview on the diagnostic approach to chronic coronary syndrome. So we are now with a short discussion moment. So questions, comments, somebody? Professor Karanfiov?
Hello, thank you for the great lecture. I'm just wondering, you showed us some emulation for intracoronary stenting, and I'm just curious how exact is the estimation whenever this simulation goes in terms of real, is there any verification for real patients? Because otherwise we are not quite precise with the estimation.
Yeah, so the study I showed you was a study that was carried out back in 2014, where they carried out the virtual stenting in 29 patients. And it's not a perfect agreement between the expected IFR and the achieved IFR, but it's a good estimation. Obviously, we need larger studies, we need longer term data with regard to it, but I think it gives us a good idea as to whether the stenting will achieve a functional benefit. We obviously know there's several studies, and it was outside my topic, but we know that there's several studies that have looked at our post-stenting IFRs or FFRs, and while we know that if we don't achieve a good post-stenting result, our patients, don't seem to have worse outcomes, but again, we don't quite know how to optimize these patients, so it's still an area that we're learning.
Okay, thank you.
Yes, Dr. De Rosa.
Nicola, congratulations to your lecture. We know there is a concern about the access to invasive techniques, mainly because of the costs. There is an uptake in the use of angio-based indices. So how is your practice in your daily routine? How often you use them? Do you even rely on them, or are they in your workbench?
Perfect. So I'm assuming you're talking about things like QFR is with regard to assessment from the angiogram. It's not something that where I work currently we have access to because of the resources. I've used it in the past, but it was predominantly in a research setting. We have relatively easy access to a pressure wire. So once a patient comes to the cath lab, adding a pressure wire to their assessment is not challenging for us. If we do non-invasive testing to start with, so for example, a CT, we don't in our system have access to CT FFR. So currently what I use in my daily practice is pressure wires.
What do you think about the core CTA study, which was practically performed in Scotland and demonstrated that doing only CTA is not enough to diagnose microvascular dysfunction? So in that regard, if the patient is symptomatic and there is nothing on the CTA but patient is still symptomatic, is that means that this patient should be scheduled for invasive assessment?
So I think this comes back to the initial assessment and your history. So certainly we do use a lot of CTCA in Scotland for screening of our patients and for patients who present to the chest pain clinic. And I know that when I see the patients, and certainly when my colleagues see the patients in the clinic, we all know there's patients that you think their history is not particularly suggestive, but they have risk factors, so you'd like to outrule significant obstructive disease. And those patients, if their CTs are normal, we tend to leave them well enough alone. However, there's also patients that we get a good history and a good sense that they are getting typical angina. And even with a normal CTCA, those patients will take them back, discuss the CTCA. If they're still getting symptoms, if they've had a trial of anti-anginals, then we tend to proceed to invasive testing in that group.
And in this regard, do you think that we should proceed also with some functional imaging for ischemia provocation, or we can directly schedule the patient to invasive assessment? Because, this is a question of time, this is a question of cost, and we should manage somehow, because there is a increasing group of patients in this group?
Yeah, absolutely. And I think it's a question of time, it's a question of resources, both our functional resources and our cath lab resources. I know at the moment there's some work ongoing for patients who have typical symptoms, have a positive stress test, and have normal CT coronary angiogram. So the patients that we previously would have called a false positive exercise stress test to assess, is that linked with coronary microvascular dysfunction or spasm? I think in clinical practice, we will often do some form of myocardial perfusion scanning in these patients, and their myocardial perfusion scanning shows ischemia, and they're not responding to the classical anti-anginal therapy, then proceed. In those with a very high index of suspicion, we'll go directly to the cath lab.
Okay, that was clear message. Okay, Dr. Ryan, thank you so much, and we will go further. Thank you for agreeing to be with us this early morning and to join our Congress. I hope to see you in the future. And,
thank you very much,
have a nice
and
day.
I wish you a very successful Congress.
Thank you. So, the next speaker will be Dr. De Rosa, who will make an overview about the pharmacological therapy in CCS.
Yes, thank you. Thank you, Professor Vasilis. I'm truly delighted to join you today for this joint session. Allow me to start with my warmest greetings to the Bulgarian Society of Interventional Cardiology. And I'd like to thank Professor Vasilis and the organizers for the kind invitation and for the hard work behind this kind of events. What you see is always the results of very long time of preparing and working hard. It's also my privilege to bring the greetings of the EAPCI, which I am honored to represent today. And really, congratulations. Congratulations for assembling an excellent program. And also, I had the chance to see how strong the collaboration between your national cardiac societies is working. And this is a very good example on how things should be, both on a national and European level. So, congratulations. So this is the hard job they asked me today. But we know we have a lot of tools in our armamentarium, thinking of non-invasive treatment for chronic coronary syndromes. So we could summarize the whole lecture using 3 keywords. These are the personalization, precision, and communication. Why personalization? We are now all well aware of the latest ESC guidelines on the topic. And we know that we have learned from the previous talk how important it is to characterize and to personalize the approach starting from the diagnostic, and then this should be translated to treatment. And as we are all interventional cardiologists in the room, of course there is a number of additional information we would like to take into account when choosing the ideal treatment for our patients. So I don't want to go through all the new and old recommendations from guidelines, but let me just use those as reminders of what is new and where the evidence is coming from. I've just taken this one to highlight the importance of lifestyle and the exercise in particular. And we will shortly understand why I'm just citing these recommendations from the guidelines. And it's also a pleasure to see that things are moving in a very similar way, and also overseas. You see here some pictures taken from the American joint guidelines from the ACC, AHA, and you see there is a common path which uses the same keywords. We could extrapolate from the European guidelines. This is a shared decision making, using the evidence but putting patients in the middle of our process. But the patients are not alone. And that's why communication should be one of our keywords, because we have the patient on board, but we should take all stakeholders on board, because we know that otherwise our strategies, doesn't matter what we are going to prescribe as a drug or interventional treatment to the patient, but they are going towards failure. And again, back to the lifestyle changes and the importance of exercise. So we know how important is to use this approach for cardiovascular prevention in the primary prevention field, but this is also very important in the secondary prevention, and we know how much it works against angina. These are data you all are aware of, taking from the Orbita study. And we see ischemia and Orbita with similar results. There was a lot of hype about the results about angina treatment in these studies, but I think this is a very strong evidence. We have an increase in exercise capacity with revascularization, which is very important because we all know how much the patient can win keeping doing exercise. But we also know that we have a strong share of anti-anginal drugs, and one of the new approaches from the 2024 guidelines was that we have not anymore first-line or second-line treatment drugs, but we have a multiple approach. We can go for one or the other based on personalization. So we can personalize the treatment based on patient's history, the endotype, the pathophysiology behind the condition, and vital parameters. How is patient blood pressure? How is patient heart rate? But we also know, and this is to introduce the next talk after my, because Dr. Kina is going to talk about PCI behind treatment of angina, but actually also before treatment of angina, because you can see here from the picture what happens if we take this is data taken from the Orbita 2 trial. You see on the left the result of PCI, and on the right the result with placebo. We have a lot of residual angina, and a consistent proportion of that is angina without any use of anti-anginals. Why is that? This is a study. This is patients are under best monitoring conditions, but of course not always these drugs are tolerated, and not always patients are persistent on taking drugs, and we know that very well. So personalization. We can now approach the patient and choose the most appropriate drug to treat angina, and this is very important to be successful and to keep the patient on board. And now the next one, this is something I care really much about when treating my patients, and this is the importance of keeping cholesterol to target levels. So we know that it is very important to maintain target of LDL, but we also know that it is very common that our patients, the ones that are coming regularly to our office, they are not achieving the goal in a high percentage of cases. And this is why the guidelines also stressed this aspect, to keep patient at target for the longest time possible. This is very important. We know nowadays we have multiple drugs. We can use different approaches. Of course, we have to be aware of the different regulation in different European countries, but I would say we are lucky enough in Europe to have reimbursement for most of the drugs we now have to treat hypercholesterolemia. And also multi-dimensional approach, trying to address not only cholesterol, but also inflammation, also cardiometabolic risk. This is very important, but this is very common nowadays among cardiologists. So I know that I'm not breaking a wall here. Every one of you I'm sure, is regularly using cardiometabolic approach. A little bit more struggling to deal with an anti-inflammatory approach. We have now colchicine in guidelines since the last edition, but we all know how difficult it is to really manage it in daily practice. So this is a challenge. This is something for the future to be addressed. And talking of personalization and precision, of course, we cannot forget that if we are looking for an endotype-based approach of treatment, we should go deeper into the different types of the different pathophysiology underlying the symptoms in our patients, and we have seen it very practically in the previous talk. And this is also very important. You see here a very new recommendation, strong one, class 1, level of evidence A, for the treatment of vasospastic angina. We've seen a very nice example in the previous talk, I think, and this is something we should be aware of while treating our patients, which it's not always easy to recognize. So it takes a little bit more time during the procedure or during our patient examination, but it's actually worth it. And then I've kept this for the last, so antiplatelet treatment. I know this is one of the things we are mostly dealing with in our daily practice. And you see here, these are new recommendations from the last guidelines. There is an approach towards personalization and precision, intensification for high-risk patients, but also demodulation of the treatment for low-risk patient, low ischemic risk and high bleeding risk patient. And the concept behind this is very clear to all of us. So there is a different time distribution, a different trajectory of the bleeding and the ischemic risk, and this is the attempt to optimize the balance between the two factors. But this is not really always easy. And that's why I like to close the lecture with doubts and not with certainties, because you may be all aware of the recent tailored CHEAP trial. This is a study that was planned in a setting of high-risk complex PCI. And you see here the two treatment approach. On one side, the conventional arm, but this conventional arm is DAPT for 12 months. On the other one is a tailored arm, where we have a low-dose ticagrelor plus aspirin for the first 6 months, and then clopidogrel alone. And the results were actually quite disappointing. You see here the primary endpoint. This is the net adverse clinical events. No different. But if you look at the percentage and at the prevalence of the events, you see here that the tailored, so the experimental arm, was the one performing worse, actually. And what's the reason behind it? So this is clearly the bleeding. So they had a very intense treatment during the first 6 months, low-dose ticagrelor plus aspirin. And this was probably the reason behind almost double incidence of bleeding among this population. And talking of doubts, you know about the uptake of drug-eluting balloons in the last years, and it's always the question around what should we do with antiplatelet treatment with these patients. There are no solid data about it. Here are some summaries I could take from consensus papers and expert review. No solid science behind it. We will see more trial coming up in the next future. But if we try to summarize all the evidence we have and try to describe what the real world is doing about it, you know, here mean dual antiplatelet treatment among users of drug-eluting balloon PCI is 130 days approximately. But if we remove the studies who prescribed per protocol 12 months, we see that the most common approach is around 3 months of dual antiplatelet treatments. Does it make sense? this will be in line with current ESC guidelines. But does it really make sense? So what is the incidence of bleeding in this patient? This is all patients taken together, stable chronic coronary syndromes, 2% incidence of bleeding. But how does bleeding correlate to the APT duration? Of course, the longer we keep the dual antiplatelet treatment, the higher the bleeding rate. And you see here that for every day of increase in the APT duration, you have almost 1.3% increase in bleeding risk. On the other hand, we have TLR. And TLR was about 6.3%. But interestingly, there is no interaction between the duration of the APT and TLR. So the bottom line here could be that shorter the APT approach after DC, the drug-eluting balloon may reduce bleeding without compromising ischemic risk. And of course, this is even more true with patients at high bleeding risk. I don't want to bring you through the complexity of this picture. This is taken from a very recent consensus statement by the European group on DCB research. You see there are a lot of factors that come into play, probably many more than with usual standard stent implantation. And of course, we have hybrid intervention, the intervention in which we use both drug-eluting stents and balloon. So this makes the things more complex, but we will have in a few days results from the solution. I think we will have many answers to this complexity. And of course, anyway, every one of us in his own daily practice has a mind in its mind, as a scheme and a schedule in its mind. This is more or less what we are trying to do at our institution. But of course, this might be, should be personalized and individualized to the specific place we are working and to the specific subset of patients you are mostly seeing. So we started with personalization, the three keywords: personalization, precision, and communication. And I think this is my take-home messages, what we should think while facing our patients to try to improve their treatment and the outcomes on the basis of what we know nowadays, but it will increase and improve with time and new evidence. So we need an intensive and personalized treatment. So personalization, it's not just personalization. We need to be intense where it's needed and mild when we are facing a safety concern. Enhanced prevention, this is very important, both in the primary and the secondary field, but we are talking of a secondary prevention with chronic coronary syndromes. These are patients which are very hard to treat, and that's why it's very important to enhance all secondary prevention measures. Better symptoms control. Symptoms are very important, not only for quality of life, but symptoms are coming from some pathophysiology background, which it's not always captured by trials. And adherence, lifestyle, digital support. This is the third keyword I was talking about. So communication is very important to keep all stakeholders on board. So public decider, treating physician, and the patient, of course. And of course, we have some evidence gaps we need to fill, but this will go on. And I think we will have very interesting news within the next future. And with that time, I stop the talk, and I hope to see you all at the EAPCI Summit next February. Thank you very much.
Thank you, Salvatore. That was a really excellent overview about the news in the treatment. So questions, comments? Yes, Professor Canofio.
Thank you, Dr. Rossi. It was really brilliant overview. I got two short questions. One is concerning lifestyle modifications. We all know that is the base for the strategy for improvement, longevity, and somehow in Bulgaria we fail to have such good dedicated program to improve this lifestyle modification. Is there any practice in Italy that you have more convincing patients to do this lifestyle modification? And second question is concerning antiplatelet strategy in drug-eluting balloon procedures. We know that the data is quite scarce and conflicting, and I'm just curious about your own protocol after these procedures in terms of which drugs and how long are you giving the therapy after the procedure?
Yes, thank you. This is improving regarding the first question. So lifestyle management. We are facing a sort of cultural revolution because both the patients and the physicians, they are thinking more in terms of lifetime management. So when they talk to the patients, not only us in the clinic, but also back home, the treating physicians, they discuss with the patients not only the next month or what will the next year be for them, but they're starting to discuss the projected trajectory in life after the first year. And I think this is one of the most important steps to move forward. What I think it's still a huge gap in our country is patients' associations. There is no solid reality with patients' associations in our country, which I think should be one of the strong drivers. We have one association which is very, very strong with the elderly population, but this is just for the elderly, and I think this is something that should be improved also on a European perspective. Regarding antiplatelet treatment, of course, if there are no specific clinical reasons, we like to keep patients 3 to 6 months on dual antiplatelet. We know that this is not only related to the local anatomy, but this is also related. The risk is also related to the clinical background of the patients, and we often have patients who have a heavy coronary disease burden, patients who are old, patients who have commonly chronic kidney disease, and of course these patients, these are not good candidates to short-term dual antiplatelet treatment, and of course this depends from your current practice with drug-eluting balloon, but I'm very often using drug-eluting balloon to reduce the stent burden. So if I have a very high burden of disease, I try to have a hybrid strategy, use the stent where it's needed, and try to avoid stent implantation where possible using the drug-eluting balloon. And of course, this is not the setting of patients you could reduce the APT duration. But if we have only the APT and it's patients with simple anatomy and no high risk like chronic kidney disease, I think 3 months could be a very good compromise.
What about prasugrel and ticagrelor? Are you using it as a...
We are using prasugrel and ticagrelor, but not on chronic coronary syndromes. This is actually not reimbursed in Italy currently for chronic coronary syndromes, so we are not allowed to. In very specific cases, we managed to get it, but it's a very low number of patients. So we mostly use it in acute coronary syndromes.
Yes, the same here, but the patients with complex interventions, and if we don't have on site immediately opportunity for ADP testing, it's a little bit hesitating about clopidogrel. And in this regard, do you use ADP testing to be sure that clopidogrel is there is no clopidogrel resistance for your patient?
We do use it, but we do not use it routinely. So it means we only use it when we have an event on ongoing treatment. because this is not, again, not covered by reimbursement. So this is a cost to the hospital. So that allows us to use it in a limited number of cases. That's why we are focusing on patients who have a risk of being non-responder.
So only a posteriori.
Yes,
Okay.
unfortunately.
Dr. Kina?
Thank you for elegant presentation. I shared our strategy in Portugal regarding the APT, and we use ticagrelor in some cases when the complexity of the PCI is higher, namely when we have a very large stent, we could utilize the ticagrelor instead of clopidogrel, even in CCS patients. We selected the type of the patient in function of the risk and bleeding risk in global, and the type of the procedure, the complexity of the procedure. So in some cases we use the ticagrelor in the chronic context. So I would like to make just a little bit comment that we partially answer yet regarding the prevention, because we know that 80% of the cardiovascular disease are preventable by lifestyle modification. And as interventional cardiologists, we face the patient when the patient came to us for the treatment, but I think that we need to move on the prevention. And as an interventional cardiologist, what do you think that is the main problem for the patient to be compliant to the lifestyle modifications? What, as an interventional cardiologist, what can we do better to convince the patient that the big part of the treatment is not just put a stent or put a bypass, but change her lifestyle modification?
Yes. Well, first is a cultural issue, and this is well known, of course. We try to address it, but we not always have the time for it. So because address the cultural issue, this is going against the stigmata of the disease, discuss the patient why it is important to accept it, not just to deny the presence of a disease, just to accept it and to do something against it. And we can do a lot. We can do a lot, as you say, to prevent it, because it is preventable. This just takes time. And we usually don't have the time you should use for it. And the other point is logistical organization. I think we should really strive to improve the patient pathway across the healthcare system, because we are seeing waiting lists prolonging because of inappropriate prescriptions. There are patients who come too often to the clinic, to the hospital, to the university hospital, and they've been to other steps of the healthcare system before. And I think this is just something we should avoid. So they should have, let's say, well-intended monitoring. For example, we often lose patients after the post-acute phase. So we try to, we managed to discuss this with the public payers, that we are now allowed to give 3 high-intensity triple treatment with cholesterol lowering just during the index hospitalization after an acute coronary syndrome, which was not allowed before, just because we otherwise just lose those patients, because they go back, and not always, less than half of them will have a visit to improve secondary prevention within the next 6 to 8 months. And of course, this is a failure for us as physicians, and this is one of the things that could improve things better. This is even more important than having a new drug or a new trial. This is very practical, very easy, but on the other hand, this is to change this practice is a huge barrier. It's not always easy to have it.
Clear enough. And the practice, unfortunately, is everywhere. As we see, the patient behavior is the same in Bulgaria, in Italy, maybe in Portugal. So I would like to invite Dr. Kina to talk about the revascularization options for CCS.
So thank you so much for having me here. It's really an honor to be here in Bulgaria to present the revascularization in chronic coronary syndrome beyond the symptoms relief towards cardiovascular risk reduction on behalf also with EAPCI. So I think that the best way to start the presentation is with a clinical case with a 77 female years old with hypertension and dyslipidemia. This patient has a chronic coronary syndrome on medical treatment during 2 years before coming to our consultation with stable angina, class 1, normal ACG and TTA, and treadmill stress tests clinically positive but without severe ischemic criteria. So when the patient came to our visit, she came because he has worsening of angina, but the ECG and transthoracic echo were normal without de novo abnormalities. Her LDL cholesterol is out of the target, and we performed a butamine stress test that show us an important area of ischemia. So we intensify the lipid-lowering therapy and proposed coronary angiography to the patient. So as you see, we have a 3-vessel coronary artery disease with a CTO of LAD, a severe lesion in the proximal circumflex, and an important disease in the right coronary artery with a more significant disease in the proximal medial segment. So in this case, the patient worsening her symptoms, previous on optimal medical therapy. So in this case, we need to think about what are the strategy that you propose to the patient, PCI, CABG, or intensified OMT. We need to orient our strategy with guidelines and scores, with heart team discussion, and take into account the patient preferences. And in this case, the patient denies the surgical strategy. So we plan to revascularization by percutaneous way. And in this context, we need to take into account if we will perform a complete versus incomplete, anatomical versus functional guided, what is the timing for physiology and intracoronary imaging, and if we proceed to more than one treatment, we should be the procedure all-in-one procedure or stage procedure. So in this case, our strategy was to start with the CTO of LAD, guided by contralateral injection in the first procedure, and then defer the treatment of circ and right coronary artery to a second procedure, oriented by RFR. So the circumflex were treated with stented in proximal segment, and right coronary artery was deferred to medical treatment because we have an RFR negative. We perform DAPT 12 months regarding the stent, the size of the stent that we implanted in LAD and circ. And in the last visit, the patient was good with no angina, normal ejection fraction, with cardiovascular risk factors on target, and with OMT, we could indeed de-escalate the beta blocker and escalate in another way the statin and ezetimibe. So beyond the symptoms relief, why revascularize the CCS patients? We know that coronary artery disease is dynamic and can unpredictable lead to a major cardiovascular event, namely myocardial infarction. We know that OMT is essential and recommended for all the patients, and revascularization may be add additional benefits on prognosis and improve the symptoms. So controversy persists regarding the benefits of add-on revascularization at the initial the presentation of the patient versus optimal medical therapy. And the contemporary RCTs lead to a shift towards a more conservative approach. But we have a rationale for revascularize these patients. We know that the more severe ischemia is, the greater is the likelihood of events. And if we could reduce the ischemia by revascularization, we could, in theory, reduce the cardiovascular events. And in the last years, we know also the concept of the vulnerable lesions and the role that the treatment of the lesions in the future of the patient. So when you take a look on the evidence, and we start almost 20 years ago with Courage trial, we know that as an initial management strategy, the patients with stable coronary artery disease, PCI did not reduce the hard endpoints, death, MI, or other cardiovascular events in patients compared to optimal medical therapy. We know that most of patients in the trial have relative mild or non-severe CADs, and approximately 15% of the patients were not treated with optimal PCI as the standards of today. Almost 20 years pass, but this is the final conclusion of the study. The same for Barry in diabetic patients. No significant difference in rates of death and major cardiovascular events. And in ischemia, the more recent and discussed trial in this scope, we also know, and the authors conclude, that among patients with stable disease and moderate and severe ischemia, we did not find evidence that initial invasive strategy was compared to initial conservative strategy reduced the risk of ischemic events or death. However, it is a study when we compare the strategy, not properly the invasive or medical therapy, but the strategy, because in the initial strategy, when we see the development of the trial, almost 25% of invasive arm were not revascularized, and on the other hand, almost 25% of the patients in conservative arm were revascularized. So we need to take into account this consideration. And when we look at the myocardial infarction, the curves are very similar that we see in FAME2 trial, with relative risk reduction of 33% at 5 years. And even if we didn't have impact on cardiovascular mortality, we have impact on myocardial infarction, that is an event itself very important for the patient. And when you look closer in spontaneous MI, if you look at the curves on the right, you could see that the conservative approach versus invasive approach, we have a higher risk of myocardial infarction in conservative initial approach in patients with invasive approach that were submitted to a PCI, CABG, or non-revascularized. So we have the opportunity to modify also the lifestyle modification measurements in this way in the invasive strategy. We also know that spontaneous and periprocedural myocardial infarction are not the same, and periprocedural MI is less important than spontaneous MI, and sometimes in some centers, I don't know what is your practice, but some centers abandoned the routine measurement of cardio biomarkers in performance the elective procedures. And ischemia extended also show us that we have a 2.2 absolute reduction in cardiovascular mortality, mainly in patients with multivessel disease. And this is the most benefit patients, without a significant difference in all-cause mortality, given an increase in 1.2% in absolute of non-cardiac mortality. Given the patients with reduced ejection fraction, REVIVE trial showed the same tendency with no changes in hard endpoints added by revascularization with PCI versus optimal medical treatment. And in the way different than the previous. We have last year the publication of the PREVENT trial. This study may raise more questions that it answers, but it is an important trial in my point of view, because it pointed out the importance of the vulnerable lesions that all of us faced in our clinical practice, and in the majority of the cases we didn't know what we do in front of these lesions. So this trial compared a strategy of optimal medical therapy versus optimal medical therapy with preventable PCI in patients with non-flow limiting lesions but with vulnerable plaques defined as the criteria as you see. And the composite endpoint composed of deaths from cardiac cause, target vessel myocardial infarction, ischemia-driven target vessel revascularization, or unplanned hospitalization was higher in a group of optimal medical therapy alone. I think we need more trials to confirm this point, and this trial have some issues we can discuss in the discussion. But I think that pointed out an important question, and I think in the next years we will discuss more about the vulnerable plaques and the role of the treatment of these plaques for the future events. But when we come back to the myocardial infarction across the randomized controlled trials, if you look at chronic context or in acute context in non-culprit lesions, there is a consistency in the reduction of myocardial infarction, spontaneous myocardial infarction. So we have no results in mortality, but we have a consistent results in myocardial infarction across the studies. So what about mortality? Why we have no changes in mortality with revascularization in any trial? Maybe because reduced event rates. When we look at acute coronary syndromes, we saw also that we have a very low rates of mortality and events, and mortality benefit in chronic coronary syndromes may be impossible to show in randomized trials, maybe. It's all about the sample size, it's another question. When you look at IMPROVE-IT and FOURIER trials, that is one of the largest trials, these trials have the same limitations. So the sample size may be 1 point of responsible for we can not show results differently in mortality. So guidelines recommend the revascularization to improve symptoms and to improve outcomes. You all know about guidelines. So what is my remarks regarding this topic? Contemporary trials have shown a benefit of revascularization in reduction of spontaneous MI. This information is consistent in all trials, in chronic coronary syndromes, also in acute coronary syndromes, but in chronic coronary syndrome, this is true. The spontaneous MI was reduced in almost trials. In vulnerable plaques, we have the signal, a positive signal. So a conservative strategy should always be initial, but we need to take into account that maybe it's then dynamic, and maybe our patient will need to invasive strategy with the course of the disease, the patient that I presented in the beginning of the presentation. So a routine invasive strategy may offer the best chance of the best outcome in most patients, in my point of view. So in whom and how? I already don't have the answer for this question. I think we have more questions than answers, but I think it's important to perform revascularization in right patient, accordingly to the patient preferences, to the patient compliance, with the right reason, according to symptoms, to multivessel disease, more proximal disease, LV dysfunction with significant disease. And when we have ischemia-driven revascularization, we need to use the tools that we have in order to provide the best treatment. If we do it, we need to do it well with intracoronary imaging and physiology to better our outcomes. So no consensus is available in whom and how. So also for the revascularization, as in the medical treatment, I think the personalized approach seems more relevant than ever in these patients. Thank you so much.
Thank you, Katarina. Great talk. So, questions, comments? Vasco?
Sorry, I did not get. Are you a proponent of the routine invasive or dynamic conservative approach? Because what you did show us that maybe both have his benefits, but the patient that you treated was a dynamic conservative actually,
Yeah.
not the routine invasive.
Yeah, I think that we need to discuss with the patient. In my practice, I could share what we perform in my practice. I think that the evidence that we have show us that the beginning strategy could be conservative and dynamic. This is, I think, this is the more important message. But dependent of the patient that I have in front, if the patient understands all of the process, if the patient wants to know the anatomy and decides the treatment in function of the anatomy and understand well the procedure, the pros and cons, the risks and benefits, sometimes I discuss with the patient and advance to the invasive strategy at the beginning of the workout diagnosis. If the patient understands the risks and benefits and it did not represent the treatment option, but knowing the anatomy invasively, stratify invasively the patient, and then we decide. I think the patient preferences is very important in decision making.
Okay. Do you think that the patients really understand the difference which we offer between the invasive treatment and conservative treatment, and when we talk about the revascularization, the real difference between surgery and PCI? What percentage do you think that practically in the real world really understand? Because the guideline now make a very tricky statement about first the heart team and second the patient decision. And we left the decision to the patient, and as we discussed yesterday the evening during the dinner with Dr. Barcin from Turkey, practically the decision is made because of sympathy. If the interventional cardiologist is more empathic, the patient goes to stenting. If the surgeon is, probably the patient will choose surgery.
This is a very, very important question. Thank you. My approach, I have two strategies depending on the understanding of the patient. If I face the patient that I understand that the patient didn't have capacity to understand what I try to explain, I tend to be more conservative. If I have no other high-risk factors in front of me, if the patient don't have the capacity to decide, and if I have no high-risk factors, I prefer a conservative approach. And namely, if I have some concern about compliance, because it's very important. In the other hand, for the very low percentage, I agree with you, for the very low percentage of the patients that have the capacity of understanding and tell me, no, doctor, I prefer to know what happened with my arteries. In these patients, I will proceed to the invasive strategy. So when I say that I take into account the patient preferences, I listened very well the patient. It takes time. We need to understand if the understanding of patient it's really true or not. But in this small percentage of cases, I will proceed with invasive strategy, and then I decide if I treat or not the patient. But I agree with you that this is a small percentage of patients. Yeah.
Sorry, a quick question. Was ischemia trial convincing enough to change your clinical practice?
Yes, because regarding this approach that I speak about, Now I'm more prone to stratify invasively the patient. I think that the ischemia don't make me more interventive in the lesions, no. But I think the post-ischemia, I stratify invasively more patients earlier. Not necessarily means that I treat more lesions, no. Maybe even, I think in some cases I will be more conservative indeed, but stratify more early the patient post-ischemia trial, yeah.
So, does that mean that you're more keen to direct the patient for coronary angiography, invasive coronary angiography, earlier than before?
Yes, if I didn't have the CT available and the patient is a high-risk patient, I send the patient to the cath lab earlier. In cases when before I perform a dobutamine stress test, CMR, now I send the patient to the cath lab to know the anatomy, and then I will decide in the future. Yeah.
Dr. De Rosa?
Allow me to be a bit provocative. So we are, these studies, so ischemia, orbita, were built to understand whether or not we are putting too many stents in our patients, or we are treating, we have a low threshold for treating coronary artery disease, let's put it that way. But what we are shifting to is to use more evidence, so of ischemia, so invasive, non-invasive, and there's a steep uptake in non-invasive functional testing using, for example, FFRCT. What we end up with is mostly a radiologist who does not know the patient so well as we might, because they don't talk to the patient. They don't have the experience we have with the disease, natural history, and they are becoming, or they might become, the gatekeepers. So you will have patients referred, so we will have patients referred for invasive coronary angiography without a real indication, and they would eventually overlook patients with high symptoms burden. So what's your idea and your strategy to counteract this?
In Portugal, in my reality, I didn't saw this problem because the CT is performed by cardiologists, only by cardiologists. And when the patient was, I work in the public health system, and when the patient was referenced to the cardiac consultation, he needs to have some cardiologic tests like echocardiogram, basal, ACG, and a history that is compatible with all of the exams. And then we decide, in the final, we decide if we proceed to the invasive approach or not. And so I think this feeling that you talk, it's a problem. I didn't realize this problem in Portugal for now, but I understand your concern about that, yeah.
That's why I'm asking, because of course if you keep being the gatekeeper, because you do it yourself, but in our country, as in many others, it's not that way, and so this is the risk.
I understand.
A little bit.
Yeah.
Thank you.
Understand.
Yes, the problem with the CT readers is a, I think, general problem in community in Europe, because there are CT scanners everywhere, but there are no good professionals who can interpret the data from CT. And this is why, for example, in Bulgaria, there is a huge disappointment from coronary CT. In my view, this is because of the reading, not because of the method. So thank you so much, and I would like to thank to all the speakers and for our audience. This great opportunity to work together with EAPCI. Thank you for coming here, Dr. Kina, Dr. De Rosa, and Dr. Ryan.